My name is Kim, and I am a forensic nurse, and I am here to talk about sexual assault exams and working effectively with people who have experienced trauma. With what we've all just listened to, felt, and been a part of, I do want to take a minute just to acknowledge a few things. First of all, I heard Heather say that she wishes that Esther were here speaking, but I heard Esther, and I know you did too. I heard Esther through Heather. I heard her through her family, and I see and feel her through every one of you who's here in this room because of the work that you do. We do need a better response to all people who have experienced sexual violence, and so let's jump in and talk about that today. First of all, it doesn't matter who we're talking about. It doesn't matter your gender, it doesn't matter your gender identity. It doesn't matter what community you identify with. It doesn't matter your age. Whether you're young or whether you're one of our elders, sexual violence can happen to every single one of us. The only commonality is that each individual who has experienced that sexual violence is different. That's really the only commonality between it all. When we interact in no matter what role that we're in, doing this work, we need to acknowledge and understand that that victim, patient, client, survivor, that person has their own unique experience that they've survived. Therefore, they're going to have their own unique responses in the moment, immediately after, and for the rest of their lives. We need to acknowledge historical trauma, and Norma just talked about that a little bit. And historical trauma is not just this idea. People forget that nursing is a science. I really believe in the science that helps me do my work. And historical trauma is supported in science. I'm talking about generational historical trauma, but I'm also talking about each individual's historical trauma. When you're interacting with a person who's experienced sexual violence, we need to acknowledge that we don't know their own personal historical trauma, such as if they experienced childhood sexual abuse or other forms of abuse. And all of those experiences are going to lend to how they interact with us, which means the burden is on us to adapt on how we respond and interact with them. Everyone's immediate needs are different, whether that's medical care, whether it's a sense of safety, whether it's knowing that their children are taken care of or that their pets are taken care of. What we think as first responders, what we think is important may not be what that person we're serving thinks is important. Their long-term needs, referrals, and resources are all going to be different. And here's one we're going to come back to, and this is a big topic. Their definition of justice may not be in line with what our definition of justice may be. And we've got to acknowledge that and understand that our motivation and how we define that may not be what that person needs for justice. And everyone's pathway to healing is going to be different. I really view all of us, whether you're here as a healthcare provider, an advocate, law enforcement, prosecutor, any role that you're in, I view our job as responding so that we can show that person where their pathway to healing starts. We can't walk that pathway for them. No one can. Every pathway to healing is going to be different. We don't know how long that path will be. We don't know if it will ever end. We don't know what obstacles, turns, and twists will be there. But our job is to help them start that journey. Really, what I'm trying to say, and really we could just do this one slide and my presentation would be over, is every single person we interact with, regardless of our role, is an individual. That means we need to see them as an individual and support them with what that individual needs. Of course, we have facility and discipline policies and procedures that we need to follow, but when we start viewing each experience that we have as a unique and individual experience that we customize so that we can reach our professional goals, we'll be a little bit more successful in that work. So let me just briefly talk about forensic nurses. I'm sure that many of you, if not most, know what a forensic nurse is, but for those of you who may be new to this work, we are nurses who provide specialized care for people who have experienced violence. We address their short and long-term health consequences, and a lot of people, including physicians and nurses who are not trained in this topic, don't understand that there are very important and life-changing health consequences as a result of sexual violence, but we're not taught that in school. So we think sexual assault, call the police, and that's not what we should be doing to serve our patients. We may address evidentiary needs, and we'll talk about evidence collection in just a moment, and we may provide testimony in criminal or civil court relative to the health care we provide, what happened in that exam, why we supported our patients in the choices that they made, and we can, if qualified as an expert witness in court, talk about our opinions on our findings and our conclusions or diagnoses. So forensic nurses can work with living victims of violent crime, or they can work in death investigation. For those of us who work with living victims of violent crime, that may be sexual assault. Many of you may know the acronym SANE, Sexual Assault Nurse Examiner. Maybe child abuse, elder abuse, human trafficking. You may work in corrections or mental health, forensic nursing, of course, intimate partner violence, psychiatric forensic nursing, mass disasters. Just to name a few, there are a lot of areas that forensic nurses work in. So forensic nursing is this big term, and SANEs, or SAFE, Sexual Assault Forensic Examiners, fall under this umbrella of forensic nursing, and that's what we're gonna spend the rest of the time talking about. Our values, we lead with unwavering commitment to our patient. So when we say we're a forensic nurse, it's really important to us that the patient understands that we work for them. We don't work for law enforcement. We don't work for the criminal justice system. We are there to serve the patient's needs. We do believe in ethical, trauma-informed, and evidence-based practice, creating a culture of inclusion. I did hear this morning the woman Ricky, who was talking about their healthcare center that they set up, how she and her team assessed the community and realized they weren't serving all of the patients that made up their community, and that's when they did outreach and worked with Norma for that relationship building in an effort to make all members of their community feel included and safe to seek care. We do like to prioritize partnerships, and our practice is driven by innovation. And again, I want to say nursing is a science, and that's what we base a lot of our healthcare decisions and interventions on. So I know this seems like a really boring term, this evidence-based practice, but there's one component to it that may surprise a lot of you. What is evidence-based practice? And I think this correlates with a lot of you who are not in healthcare, but are still responding to sexual violence. We make our decisions and what we offer to our patients based on what the research tells us. So what does science say is best for therapeutic outcomes? What does our own clinical experience tell us is right for our patient? But this is the one that surprises a lot of people, and this is a huge part of what goes into evidence-based practice, and that is the patient choices. That's not driven by science. That's not driven by our own clinical experience. That's driven by the patient. And what the patient wants done or doesn't want done is one of the pillars, one of the three pillars of evidence-based practice. And sometimes we need to be able to articulate that in the courtroom if we're being challenged on something we did or didn't do in the exam room that might be best practice according to a state or national protocol. Yet if our patient didn't want us to do that part, we are going to support our patient in that, because that is a part of evidence-based practice, and it is a part of what leads to therapeutic outcomes. So let's talk more about that individual, the patient, and their responses. But even more importantly, what the discussion needs to be is not about what that patient, victim, or survivor's response is, but what our response is to their responses. So I know that many of you have to address these following hurdles just like we do as forensic nurses. That question, well, why didn't that person fight, yell, or try to get away? I would have done that. If that was happening to me, I would have done everything in my power to get away. How about this one? They don't seem like they've just been through something horrible. How can they be telling me about this terrible experience with no emotion? So we're talking about patient or victim reactions, but really what we're talking about is our reaction to them. What we know now, and I'm with many of you who have talked about being in this work for 30 years. I've been a nurse for almost 30 years now. Don't try to do the math. If I tell you my age, it's not going to match up, but don't worry about that. What we now know, and we didn't have when I first started doing this work, is more science on the neurobiology of trauma. And what that research tells us is we actually, and by we, I don't just mean the patients and the victims that we serve, I mean all of us as humans. We do not have a choice in the way we react and respond during, after, and long-term from a trauma. So when you have a perceived threat on your life, like a sexual assault, like strangulation, like child abuse, like intimate partner violence, your body goes into a defense mode and you have no choice in what happens. We do know that you can fight, you can try to get away, or you can freeze. The most common reaction tends to be freezing, whether that's for a long time or a short moment or anywhere in between. That is the most common reaction. It can also be a combination. It's not so linear where you're going to either do one or the other of these three options. It's possible that there can be a combination, and that can be changing and vacillating during this traumatic event. What we do know is that it's involuntary. It's not a choice. And I know this is a horrible example, and I apologize, but it's a good one for us all to put ourselves in a traumatic situation. If somebody came in this room right now with a gun and started shooting, the neurobiology of trauma would apply to all of us. We would all have an involuntary reaction to what was happening. Maybe that's going to be to rush the person. Maybe it's going to be to try to get out another door. And maybe it's going to be to freeze and sit there and watch what's happening and want to be able to react, but you are unable to do so. So why? This is because an area of our brain takes over, and it's really our defense circuitry taking over. And let's talk about the why behind that. Just briefly, I promise. So this is your brain. The part to your left of the screen is the front. It's like looking at a profile. It's your forehead. That's our prefrontal cortex, and it helps us with complex thinking. That's a part of our brain that has evolved. So if this, then that, it's our rational thinking. Like when we're saying, if I had been through this trauma, I wouldn't be reacting like that. That's our prefrontal cortex working. But during a trauma, that shuts down. And your amygdala, which is this tiny part in the center of your brain, your more primitive part of your brain, it takes over. It's triggered, and the amygdala triggers the hypothalamus, which is the communication center of your brain, and it sends all of these signals, and one of those signals goes to your pituitary gland. And the pituitary gland is a gland in your brain that signals all the other glands throughout your body. We have lots of glands throughout our body. And here's something interesting. During this trauma, it triggers the adrenal glands, which actually sit on top of your kidneys. And those adrenal glands, they dump out hormones. So amygdala to the hypothalamus, to the pituitary, to the adrenal glands. And they dump out, and this is what would be happening to all of us, four hormones: catecholamines, cortisol, opioids, and oxytocin. And it can be in different concentrations. That might be why some of you rush the shooter, some of you hide under the tables or try to get out the doors, and why some of us may be frozen, because I may have more opioids and you may have more catecholamines, and we have no control over this. So catecholamines and cortisol, they are what react to either help us fight, flee, but sometimes in combination, that is what can make us freeze. Opioids are really interesting to me. You've probably had opioids before, because we produce opioids to give you pain medication when you're in pain, and you come into our emergency department and we need you to not be in pain so that we can treat you and you can answer our questions. But our body produces small amounts of opioids as well. And opioids are a natural pain reliever, but they also block all emotion. That may be why when we're talking to a person who is relaying a trauma, a horrific event, that they have a very flat affect, because they have high opioid concentration in their blood. Oxytocin is a really interesting one to me. I know there's some nurses here in the audience who do a lot of work going into homes post-pregnancy to help with education and support for new moms. I used to be a labor and delivery nurse 28 years ago, don't tell anybody. And oxytocin is what we put into the IV bag when we want to induce labor. And it makes your uterus contract and it puts you into labor. It's also one of the things that's released during breastfeeding to promote bonding. It's a feel-good hormone. And we believe that this may be why sometimes you're talking to somebody who's relaying a horrific event and they may smile or laugh in what we consider to be, an abnormal reaction. Thank you. In what we consider to be an abnormal reaction, but it's possible that it's just a lot of oxytocin that is coursing through the body. So, now that we know about some of those hormones and that our victims, patients, survivors, and clients have no choice in how they react during or immediately after, how do we change how we approach them so that they are not re-traumatized by the system and so that we are better able to gather the information and do the work that we are tasked with doing for keeping our community safe, for providing services to that individual, that person. So that's something I want to challenge you, is to really think about what you're doing in your practice that might need to change based on this. I know in healthcare, we're asking patients to make the decision, do you want to report or not report? When they've got all these hormones coursing through their body, we're asking them to relay information, details about this event or events, when they've got all these hormones coursing through their body. Do we need to change those time frames? So I am going to briefly talk about the medical forensic exam, and I want you to put on your professional hat in whatever area of work you do. I'm going to go through it quickly, but I want you to be thinking about the concepts that we utilize in the medical forensic exam to approach our patients and how that may translate into the work that you do if your work is not healthcare related. So I want you to know that each exam is tailored to the specific circumstance, to that specific patient. And it is the patient that makes the decisions and is the one that is ultimately in control. Power and control has been utilized over them. Control of their body has been taken away. The most therapeutic thing that we can do, well, there's two things. Number one, as healthcare providers, is allow the patient to regain control of their body by making choices. And we support them in their choices, even if internally we were wishing they were making a different choice. And the other one is making sure that we're using communication that relays to that patient that they are here having to make these decisions because of a choice somebody else made. And I've heard this theme a couple of times over the last 2 days. Dr. Corcoran this morning talked about how it's so personally embarrassing for people to have to tell about what happened to first responders in healthcare. But we need to make sure that when we're asking those questions, what happened to you? What did somebody else do? This isn't the person that we're serving. They didn't make any choices to be answering these questions. Somebody else made the choice. And sometimes we need, as forensic nurses, to say to our patient, when we see them struggling to make a choice, I'm very sorry that you are having to make these difficult decisions because of a choice somebody else made. What are we doing in that moment? We are reminding them that this is offender-created outcomes for their patient. So when Norma was just up here talking about how people are turned away because of substance abuse issues, addiction issues, dependency issues, we need to remember collectively that using drugs or alcohol to cope with some of the horrors that you have to face every day is an effective coping mechanism. But is it possible that this is a offender-created coping mechanism and not the patient's choice? It's not a healthy coping mechanism, but it's an effective coping mechanism when you need to numb your feelings to get through the terrible things that are happening to you. Again, I'm going to go back to that evidence-based practice. Yes, we're talking about what science tells us. Yes, we're talking about our own clinical practice and experiences, but we are also talking about patient choices. So I will say to patients in my care, I'm going to offer to do a lot of things for you today, and you can choose to do everything I offer. You can also choose to do nothing that I offer, or you can choose to do some of the things that I offer, and I'm going to support you in that. We do need to make sure that we provide informed consent. If they choose to have a medical exam, we are going to be documenting things. They have a right to that documentation, so they can come and get that documentation. That's their health record. But if this health record is going to be used potentially in the criminal justice system for both possible investigation and possible prosecution, they have a right to know that the questions we're asking are going to be documented, and others may see that. Therefore, they have a right to not answer a question we ask. And that's not refusing to answer, that is declining to answer because we are giving them the option to answer or not. We are going to provide them reporting options, such as, do you want to report this to law enforcement if you're over the age of 18, or do you want to remain anonymous? And these anonymous options came about not because we don't want things investigated, but because we want people to feel safe and secure to reach out for help when they need it. If they can come in and remain anonymous and get a medical exam, have potentially evidence collected, and then they change their mind, they can convert from that anonymous report back to a traditional reported to law enforcement, and at least they've received the health care they've needed, and at least they've got the evidence collected that may be useful. And again, that is taking the power and control away from us and putting it where it belongs and in that patient or victim's hands. So this is the last bullet point or dot point on this slide, but is perhaps the most crucial message for every healthcare provider out there. And I truly believe that the most important intervention I can offer a patient who has been the victim of any type of violent crime is access to confidential advocacy. I can take responsibility for what I do as a nurse in that exam room, but I can't provide services for that patient once they're released from my care unless it's healthcare related. Law enforcement can provide services for that patient when it comes to investigation, safety issues, but they can't meet that patient's or that victim's every need. Prosecutors can help fight for justice and provide services for that victim and their family, but they can't meet every need. Who can meet every need? And that is an advocate. And that is that patient's choice, should they choose to utilize the advocate in that moment or down the road. We know that there are lasting short and long-term health consequences related to violence. We know that oftentimes the people we're taking care of are not experiencing one episode of violence, they're experiencing many episodes of violence. What intervention is going to be able to assist in safety and planning should that patient choose to return to a violent relationship? An advocate. Who's going to help them safety plan if they want to attempt to safely leave an abusive relationship? An advocate. Who is going to help them safety plan and remain safe if they have successfully left but remain in danger? An advocate. Who can help them access health needs? An advocate. Counseling needs? An advocate. Criminal justice needs like protection orders? An advocate. You see the theme? Advocacy is actually a healthcare intervention, and it is one of the most important interventions we can offer our patients. Every patient who has experienced violence deserves an advocacy response, and that is our job to make sure they're connected. And it's also our job to understand they may not want to utilize advocacy in the moment, but it's still our job to educate so that they have access to confidential advocacy down the road should they choose to utilize that. broad components of a medical forensic exam, or a SANE, sexual assault nurse examination. We do ask for a history. We ask for their medical history so we know what health conditions they had prior to the assault and what may impact some of our findings. And then we do ask a little bit of psychosocial questions. Where do you live? Are you in school? Do you work? Who do you live with? That helps us understand their resources and their limitations for safety planning and some information that we need to give them, instructions on discharge. We do a physical assessment. We do a detailed anal and or genital assessment based on the history they're providing us. And we can collect forensic evidence with patients' consent. We do not collect evidence without their consent. And we make sure that those patients understand just because you're signing this piece of paper that says you would like us to collect evidence doesn't mean that you have to submit every step. We will still, throughout the process, ask your verbal consent, and you have the right to say, yes, it's okay to collect that, or no, thank you, I decline that step. When we're taking a history with our patients, we do emphasize that we are not investigators. And here's pretty much what I say to a patient. We're now to the part of the exam where I need to ask you about what happened to you to bring you into this exam room today. I need you to remember that I'm not law enforcement. I am your nurse, so I need to know very different information than law enforcement would need to know. I need to know, how did things start, exactly what happened to your body, and how did they end. I'm going to be writing this down, so usually I write a little bit slower than my patients talk, so if I need to have you pause for a moment, it's only because I want to make sure that I'm getting your words down and not my interpretation of your words. Whenever you're ready, go ahead. And here's something really interesting, and I do believe any one of the nurses in this room who has ever conducted even one sexual assault exam would probably support me in this statement, because this has been my clinical experience. People say that must be the worst part of the exam, to have to tell a strange nurse about this terrible thing that happened to you. And I am here, I've done over 2,500 sexual assault exams, and that doesn't count like child abuse, trafficking, and intimate partner violence, just simple sexual assaults. And I can now tell you, it didn't take me very long to realize, giving the history of that traumatic event, that sexual assault, is not easy. It is not easy, but when you have a nurse who says, I'm going to take the information you give me so that I know better how to take care of you. I will know better where to look for injury, where to look for disease, and if they want evidence collected, where there may be potential evidence. When you give that patient the rationale for why you're asking, it's like you give them permission to give you every detail about what happened. Details they may not share with the people closest to them in their life, because we're all humans and we don't want to traumatize the people that we love and who are trying to help us. And again, it's not easy, but what I have found is one of the most therapeutic things I can do for my patients is be fully present for them and in the moment and bear witness to what they have survived. And while it's not easy, sometimes I think it's very therapeutic. It's important that I keep a blank face, because if I go, oh, ew, that's terrible, I'm so sorry, that's going to make them pull back and not give me the details, because they are human, we've bonded quickly, and they don't want to hurt me. So blank face, and I say a lot of, okay, and then what happened? Okay, and then what happened? So I'm gonna, just for a second, take a sidestep and talk about something else. I have now realized that when we talk about compassion fatigue, resiliency, all of the stress and the heartache that we have in the work that we do, sometimes we need that too. We need people to bear witness to the terrible things we see and hear and do at work. And that may be a coworker who understands, that may be a therapist or a counselor, but somebody who is equipped and understands, and somebody who is able to respond with, you know what, Kim, that's really terrible. I'm sorry you had to do that at work today, but I'm really glad you were there for that patient. I know you're a great nurse, and that you were meant to be that patient's nurse. That's not the time to critique and say, well, you could have done this, you should have done this. if you're that coworker. But I just want you to think about that. Maybe once in a while we need people to bear witness to the things that we do at work. All right, I'm doing a sidestep again. Back over to the patient. So all of this, we're formulating our plan of care for this specific patient. We do a head-to-toe examination. We want to make sure that there aren't subtle injuries on patients who have darker skin tone, like American Indian, Alaska Native, Latino, Latina, Black patients. We need to slow down because it can be much more difficult to see subtle injury like bruising, petechiae. We need to make sure that we're palpating with permission, gentle touch on the head, on the arms, on the legs, the hips, to make sure that there's not tenderness, because sometimes bruises are there. We're just not able to see them because they're deeper in the tissues, or because that patient's darker skin pigmentation is hiding a bruise. So we do need to be very thoughtful and, what's the word I'm looking for? We need to be very intentional with a slow, methodical assessment for each and every patient. We may be photo documenting that body surface injury with the patient's consent. And then we may be doing a detailed anal and or genital exam based on what their history of the assault or assaults was. We do collect evidence. So that is with patient consent. It is within the protocol or the standards and expectations of the facility we're working in, perhaps the region, like the state of South Dakota, as well as national protocols. All of those go into play with what we do and don't offer to collect, but at the end of the day, the ultimate authority on what we do and don't collect is that patient. Evidence collection is an important component of our exam, but it is not the only thing we do. Our most important component of our exam is addressing the health needs of that patient, and evidence collection may or may not be a component. I do want to challenge you with this. Let's say that you are law enforcement and you are notified by a confidential advocate of a patient or of a victim that was sexually assaulted. This victim wants to make a report and have an investigation, and they are going to the hospital where the local SANE program is. And this was acute, meaning within evidence collection time frame. Let's say it happened 2 days ago, so we certainly can collect evidence after 2 days. And that nurse and that patient are interacting, and the patient says, "I don't want you to collect evidence." Does that mean that that exam is no longer beneficial in terms of criminal justice, in terms of an investigation or prosecution? I actually see, from my perspective up here, law enforcement shaking their head no. And that is a well-informed and educated, smart law enforcement entity who knows our interaction with the patient, even when there's not evidence collection, that is evidence. All it takes is a subpoena for my documentation to become evidence. If there are prosecutors in the room, would you rather have, for evidence in a sexual assault trial, an ER doctor or nurse who's never been trained in sexual assault response, but they've done a kit, they just like looked at the kit and followed the directions and handed you the kit? Would you rather have that professional, medical professional with the kit testifying, or a SANE nurse who's trained in all of this but didn't collect evidence, who's in that courtroom testifying to injury, lack of injury, why it's okay that patients don't opt for evidence, why it's normal to have a flat affect, why it's normal to wait several days, weeks, months, or years before you disclose what's happened to you? And any experienced prosecutor is going to say, I want the same. So it's not just about the biological and physical evidence we collect, it's really about our whole interaction. And I don't know how it is in your community, but I challenge you, if you have a SANE program in your community, and the protocol is that they can only be called in to do an exam when there's evidence collection, I challenge you to change that. All patients who are disclosing a sexual assault deserve a healthcare response. Just because they're outside of evidence collection does not mean that those health consequences disappear. I understand that sometimes it's about funding and reimbursement, and sometimes the only time that SANE program can get reimbursed is if evidence is collected, but that's why it's up to our collective disciplines who respond to sexual violence to come up with an alternative solution to that. We do go through treatment options. This may be sexually transmitted infection prevention. Do you know that if somebody is sexually assaulted and they're exposed to HIV during that assault, if you can get to a hospital within 72 hours, we have medication that prevents you from acquiring HIV. And I say that with such emphasis because when I became a nurse 30 years ago, I couldn't say that. And I didn't believe in my lifetime I would be able to say it. If you've been exposed to HIV and you can get to a hospital that has HIV prophylaxis within 72 hours, we can prevent you from acquiring HIV. That's why time is of the essence. Emergency birth control. If you have a patient who has the ability to become pregnant from their sexual assault, they should have the right to emergency birth control. And what I need you to know about this is not an abortive agent. If I was pregnant from my husband and say I was only 6 or 7 weeks pregnant and I didn't realize I was pregnant, and I took the medication that we give sexual assault patients to prevent pregnancy, those meds do not abort a pregnancy that is already implanted. It prevents a pregnancy from implanting. It doesn't abort a pregnancy. We can also do immunizations like the HPV, hepatitis, and tetanus. We do a lot of education for our patient at the end, referrals, and provide resources. We do need to make sure that we're verbally giving them these as well as written, because we know that only about 10% of what we teach a patient is retained. So drug-facilitated sexual assault, we heard Jonathan Curlin talk about that yesterday. Their evidence, where is it going? How do they find out the results? If there's injury, no injury, their STI meds they took, if we tested for STIs, sexually transmitted infections, memory recall. Why would we talk to patients about memory recall on their discharge instructions? It's because we say to patients, we know that you may not have been able to tell us everything today that happened. Memories may be coming back to you in the next hours, days, weeks, or months, and if you remember another detail that you think is important, it's okay to tell law enforcement about that. We understand that those memories aren't all retrievable right now. I lost my PowerPoint again, I'm so sorry. So let's bring it back to you and as a collective on. Thank you for your help. Oh, let's not bring it back to you quite yet. The SANE nurses, forensic nurse examiners, we do have criminal justice obligations, and this is just a brief slide. This relates to law enforcement as well as to attorneys. We can let them know if the assessment that we did is consistent with what the patient's history is. We can talk to law enforcement about that. We can speak to it in the courtroom. We can also speak about general healthcare concepts, exam components, and the rationale behind our care and diagnosis. Crucial facts for you to know. I know many of you already know these two things. If these are new facts to you, I am doing a breakout session and I am more than happy to talk about this more in detail. Number one, it is medically impossible to determine virginity. So if you bring a little 6-year-old girl in for a SANE exam and you want to know if she has been penetrated, we are not able to tell you that. Virginity tests are a myth. You cannot medically determine virginity. We have all been lied to. I will give you the medical reason and rationale behind that if you would like in the breakout session, or you can corner me at any time the rest of today and I will be happy to talk to you about this. Just ask my 2 adult sons. They know I'm happy to talk about it. The most common finding related to injury is that lack of injury is our most common finding. Doesn't matter your gender, doesn't matter your age, doesn't matter the time frame between the assault and the exam, doesn't matter the nature of the assault. Lack of injury is the most common finding. Lack of injury does not mean that this person did not suffer a very violent assault. We want our exams to be therapeutic, not traumatic. Again, it is not fun coming in for this exam. Nobody wants to come in for this exam, but we hope that at the end of the exam, our patients have come down and from their stress a little bit. They have regained some sense of control and autonomy over their body and the situation, and that we have connected them to services that will best serve them. So we want our exams to be therapeutic, not traumatic, but isn't that what we all strive for? Regardless of your role, your discipline, you want to serve your people the best way possible. You want to be therapeutic and not traumatic. So I want you to ask yourself this: how do we accomplish a therapeutic response as an individual? Whoever you are, whatever you do, what change can you make to be more therapeutic? What can we do as a discipline? What can law enforcement do? What can nurses do? What can advocates do? What can attorneys do? What can we do to be more therapeutic as a discipline? And what can we do to be more therapeutic as a coordinated community response? All of us together. What laws need to change? What protocols, policy, what education needs to be had? There's a newer study out called Reporting Sexual Assault Survivors' Satisfaction with Sexual Assault Response Personnel. It was published in 2020. Not a very big study, 460 participants. They were all women over the age of 18 who had survived at least one sexual assault. But there was some interesting information, because when you go looking for what survivors want, need, have experienced, there's not as much research out there versus what we need. What I need as a nurse, what you need as law enforcement. So that's why this study spoke to me a little bit. These survivors were asked about advocates, forensic nurses, patrol officers, detectives, and state's attorneys' offices. The findings basically said that advocates and forensic nurses received similarly high satisfaction ratings. Patrol officers, detectives, and state's attorney office staff received similar ratings, though lower than nurses and advocates. The study does also recognize that this is a little bit unfair to compare nurses and advocates to the other people, because advocates serve one entity. Nurses are there to serve the patient, where the other disciplines that we have listed there, they have a duty and obligation to look at both sides. So there is a little bit of unfairness there. However, that doesn't take away the fact that we need to do some self-examination. But here's the most interesting point to me. A very small percentage of these 460 people, a very small percentage were survivors who interacted with all 5 of those response personnel, and they reported much higher satisfaction scores than the other people who had only interacted with a few of them. So there's some food for thought. When we all come together as a community and address this, we are actually serving our community much better. The higher satisfaction scores correlated when response personnel displayed the following behaviors: respectful treatment. How can you make any changes for more respectful treatment? Clearly explain procedures. Law enforcement, when you simply say, I am going to have to ask you some questions that are difficult and they may seem victim blaming, but I need you to know that these are questions that I have to ask so that I can help you better. Attorneys, when you say you're prepping a victim for court and you know in the courtroom those jurors are going to be like, well, there was this college party going on or party in this house and she's being sexually assaulted in this room and there's people right outside that door. Why didn't she yell for help? You have to ask that question because it's going to come up in court. But instead of asking it in the traditional way we would, if you were to say, what made you feel like you couldn't yell for help? That is one small, subtle change that makes all the difference in the world. And instead of feeling defensive, you've now opened the door for that person, that victim, to give you a much better explanation. Believed their stories, that's not surprising, and demonstrated cultural sensitivity. Overwhelmingly, these were the themes that survivors wanted from all response personnel. So, again, how do we accomplish these things as individuals, disciplines, and as a coordinated community response? So here's where I'm going away from the science. This is my ending. I'm trying to go fast because I know we got a little bit off track for very good reasons. This is my opinion, but I do believe that many of you would support me in these opinions, but it's okay if you disagree with me. First of all, humility. We have to have humility in the work that we do. And if I were to stand up here and boast about the over 2,500 sexual assault exams I did, and I said, you know, I'm gonna make up this list, I think I'm one of the top 10 best forensic nurses in the world. First of all, it would be a list that I created and I'm the only person voting because there's no way I'm in the top 10 best forensic nurses in the world. But what I'm saying is I'm confident that I am a good forensic nurse and I am confident that I serve my patients well. But I have to have humility that I don't know each and every person and each and every patient. So I must approach them understanding that what I know typically may not be applicable to this patient. I'm going to give you an example. This happened to me. I was taking care of a particularly terrible situation where this is very unusual, but my patient was harmed so terribly in her sexual assault that she was having to go to surgery for a perforated rectum. And we were waiting for surgery. And I'm sitting there talking to her, and I really, you know what I mean? You have like a person you're serving and they remind you of like your sister or your kid. This one threw me because this patient reminded me of myself. And I had not ever had that before. She was a nurse. She was articulate. She was a very good caregiver. And we got bumped for surgery because of a head-on collision that had happened. I work in a level 1 trauma center, and so these 2 kids were flown in via helicopter, and so she had to wait even longer for her surgery. So she's laying in the bed, and I'm chatting with her, and I'm sitting on the stool next to her, and a couple times I lean over and I touch her leg or her arm, and she flinches. Why? Because I need to ask permission before I touch a patient, and for whatever reason, I was so comfortable with her that day, I wasn't asking permission, and the 3rd time I did it, I said, Debbie, I am so sorry I keep touching you. I see that I'm startling you. I know better than that. I need to apologize. And she looked at me. I'm sitting on the stool. She's laying in this bed. She looked at me like I was the craziest person in the world. And she said, Kim, I am not flinching because you are startling me or upsetting me. When you do that, it actually is really comfortable. Like it's very comforting. She said, I am covered in stool and blood. And I know that you're going to sit in your personal car and you're going to go home to your family. And I'm so dirty, I don't want to make you dirty. So here I am thinking I know all about trauma-informed care and why this patient's flinching. And I don't know anything because I don't really know her. She's caretaking me because she's a nurse. And in that moment, I took my gloves off and I touched her forearm with my bare hands to her bare skin. And I said, Debbie, you are not dirty. A dirty, dirty thing happened to you, but you are not dirty. And we both got tearful and then dried it up and moved on. But that is a moment that nobody can ever take away from me. Nobody can ever take it away from her. And that is, I know every one of you is thinking about different instances you have had in the work that you do that is similar to that. But my point is we must, no matter how experienced and how good we are, still approach our work with humility. The next one is justice. I'm going to challenge you to think to yourself, if I can't define justice as putting the bad person in jail, how do I achieve justice for the people I serve in my role? This is much easier for advocates and nurses to do than it is for law enforcement and prosecutors. I recognize that. But I do want to challenge you. What can I do for these people, my people, the people I am here to serve? How can I help them achieve justice if it can't be a successful court outcome? And the last is faith. which may be a little bit contradictory to the humility, but in order for us to be successful in the work that we do, we have to balance our humility with our faith in ourselves, with our faith in the work that we do. I was speaking at an international conference once, and the topic was intimate partner violence. So there's all these forensic nurses in, probably about the size of this, and we're starting the presentation, and this woman in the back, an older lady, raises her hand and stands up and says, "I just need to share something with you. I am here," because it was a day-long workshop, they had to pay extra to go to this pre-conference workshop. "I am here today to learn about how to better take care of my patients, because we see so much domestic violence. We see so much domestic violence that we had this woman in our community who came into us, and her husband had hurt her so badly. And then we saw her again, and she kept going back to him. She kept going back to him, and we saw her 9 times. And then one day I sat down at my kitchen table, with my cup of coffee, and I opened the paper and I saw the news story, he killed her. What can we do better? How did we not serve her? How did we not help her? What can we do better so that our patients don't get killed?" And I said to her, "I have a very different perspective than you do, because I'm not you, I'm not in your community, I didn't take care of her. But what I hear you saying is this person needed help 9 times and returned to you 9 times because she felt safe, understood, and she knew you would address her health needs. So while you see that as a failure, I see it as a success." And so did she, because you know what? You don't get to take responsibility for a choice someone else made. And that was the person who killed her. The only thing you get to take responsibility are for the things that are within your control. So have your humility. Think about how you define justice if it can't be the bad person goes to jail. But have faith in what you do every day. It makes a difference. It makes an impact. You may not see it, but you have to have faith in yourself and know it. Have faith in yourself. Have faith in the work you do. Know that what you do matters and who you are matters. Thank you for being here and for listening. And thank you for always inspiring me to do better work as well.